Good afternoon. I'm Sarah Allender. I'm the Deputy Director and Senior Fellow at the Global Health Policy Center at the Center for Strategic and International Studies. I'd like to welcome you here today for our event with a big shout out of thanks to Kaiser Family Foundation for hosting us here today. Today's event on assessing South Africa's HIV progress and priorities for AIDS 2016 in Durban has been sponsored with support by the Bill and Melinda Gates Foundation, so we'd like to thank them as well. The Global Health Policy Center has been taking a detailed look at the United States' most important health partnerships around the world to trace their evolution, their impact on public health, and consider how they may evolve for the future. The focus countries include Ethiopia, Nigeria, India, and South Africa. The report you will hear about today is one of the results of that research. CSIS organized and led a congressional staff delegation to South Africa in February, which followed on an earlier report we did on South Africa last year. So why did we focus on South Africa? First, it remains the global epicenter of the HIV pandemic. There are an estimated 6.8 million people living with HIV and upwards of 300 new infections each year. It is perhaps the most important PEPFAR relationship, a place where PEPFAR has been involved from the beginning and has undergone several radical transformations, evolving from a program that worked first around the government to now with the government. It's been successfully handed off to the South African government, in many ways, the responsibility for care and treatment for South Africans living with HIV. South Africa is also a place where country leadership is a reality, not just an aspirational goal. The strong partnership has led to more than 3 million South Africans on antiretroviral treatment. For all of these reasons, South Africa matters. The success of PEPFAR globally is highly dependent on this relationship and the success in South Africa. Today's event is a chance to reflect on some of the findings from our new report, to consider the progress South Africa has made in tackling HIV/AIDS with the significant support of PEPFAR, but also to discuss how do we support that momentum. It is also a chance to look ahead at a significant event that South Africa is hosting next month, the 21st International AIDS Conference, which will be held in Durban. Our panelists will consider the significance of AIDS 2016 as a platform to give renewed impetus to and strategic direction to the global fight against HIV. They'll offer their thoughts on what South Africa, the United States, and the global public health community will be hoping to achieve there. Before we turn to our panel discussion, it's my pleasure to introduce my colleague, Richard Downey, to present the findings of the report. Mr. Downey is Deputy Director and Fellow with the CSIS Africa program. In this role, he analyzes emerging political, economic, social, and security trends in sub-Saharan Africa with the aim of informing U.S. policymakers, the U.S. military, and members of Congress. Mr. Downey joined CSIS following a decade-long career in journalism. He was a reporter for several newspapers in the United Kingdom before joining the British Broadcasting Corporation, where he worked as a senior broadcast journalist covering the leading international stories of the day for radio and television. He is a frequent commentator on African issues for the BBC, Al Jazeera, CNN, and other international media. Richard.
Hello, everyone. Nice to see so many of you here today. Just echoing Sarah's thanks before we begin to the Kaiser Family Foundation for hosting us. And thanks also from me to the other members of the Congressional staff who took time out of their very, very busy schedules to join me and the other members of the CSIS team on our trip to South Africa. It was a bipartisan group. Everyone was very engaged and active and involved. The report that you see today really was a group effort. Having said that, hold me solely responsible for any of the contents that you don't like or wish to challenge. I'd like to thank my CSIS colleagues who helped a lot and actually played really significant roles on the trip. In particular, Audrey Jackson and Sahil Angelo, who can't be with us today. And also our congressional staff, Nick Barth and Mary Sumter Lipinski from the Senate side, Leslie Ann Warner from the House side. Sarah's done an excellent job of providing the backdrop and context to why the rationale for going to South Africa was important to us. She sketched, did a good thumbnail sketch of the history of PEPFAR and its involvement, long involvement in South Africa. And we visited at a really important and crucial time as PEPFAR was implementing its latest strategy, 3.0, the pivot, focus for impact, as it's called locally, choose your title. But so we got to see firsthand some of the major operational shifts that the so-called pivot was triggering on the ground. It was also an interesting and a turbulent time, frankly, to be in South Africa, which was and still is experiencing a period of political ferment, economic hardship, and social disharmony that's perhaps unprecedented in the era of multiracial democracy. So we were interested during our trip in looking at how these external factors affected South Africa's decisions on how to allocate resources to health and to HIV/AIDS specifically. Just in terms of our takeaways, I won't run through them all. You hopefully have the report in front of you. But I think first and foremost, we were struck, the members of the group, with the progress South Africa has made as the country with the largest HIV burden in the region with the largest burden of HIV. The government has come an awful long way since those days of AIDS denialism under President Mbeki. Now takes a strong lead in tackling the disease and funding, most importantly, the response. South Africa, as we heard, is the home to the world's biggest HIV/AIDS and treatment program. 3.4 million people receiving antiretroviral therapy. At least that was a number during our visit in February. Impressive progress made in reducing mother-to-child transmission, now under 1.5%. Very good working relationships between the host government and the main donors, including the United States. And that's despite frequent strains in the overall bilateral relationship. And coordination has improved, both between South Africa and the US, and with and among the other main donors as well. South Africa's fight against HIV has also importantly benefited in the South Africa context from the contributions of really strong and diverse constituencies, an active government, a highly impressive scientific and research community, brave and loud civil society organizations, and an engaged private sector. Having said all that, though, the challenges are immense, and they confronted us at every turn of this trip. First, I think it's important to acknowledge just the extraordinary health needs of South Africa and South Africans in general, both in terms of general health and for HIV specifically, which was the focus of our trip. Yes, South Africa has the world's largest HIV treatment program, which is obviously wonderful, but there are still more than 3 million people who aren't receiving antiretroviral treatment. And appallingly high numbers of people are still getting infected, most notably young women and adolescent girls in the 15 to 24 years age bracket, where you're still seeing around 2,500 new infections every week. Now, cracking this problem is fiendishly difficult. It involves chipping away at some of the prevailing social, economic, behavioral conditions that just don't change overnight. Things like stigma, poverty, gender-based violence. Adding to the challenge of tackling HIV is that HIV is intertwined in the South African context with another terrible yet comparatively neglected disease, at least until recently, and that's TB. TB is now the #1 cause of death from disease in South Africa. And you're seeing an alarming increase in multi-drug resistant TB as well, which of course is very, very difficult and very expensive to treat. Now, faced with this huge health burden, the resources South Africa has available, they may be plentiful compared with other PEPFAR countries perhaps, but they suddenly look a lot more limited within this context of need. South Africa faces the challenge of sustaining a vast ART program with a stagnant economy and with donor support projected to flatline and taper off in time. Human resources for health in South Africa are in a precarious state. We heard estimates that South Africa needs something in the region of 5,000 new doctors every year, but you only have 1,800 graduating from medical school, and at least half of that number choose to practice overseas and within the private sector as well. visit any rural community as we did during this trip, and conditions are just very, very tough. It's hard to run a clinic, for example, when you don't have reliable electricity supply. And it's not just a case of resources being tight. I think the way South Africa's resources are allocated is unequal on a scale that you don't see in many countries around the world. In healthcare, you see this really glaring divide between the sort of very well-resourced private system that receives about 50% of overall health expenditure in South Africa, but only serves around 16% of the population. And ambitious, the South African government is very, very much aware of this and has unveiled an ambitious program for universal health coverage. But there are serious questions about how it will be financed and supported and implemented. In addition, it's important to note that resources are being misspent and wasted. Allegations of corruption and nepotism have slowly eroded the credibility of President Zuma and some in his administration. It's put the ruling ANC on the defensive. In the health sector, the national government struggles to manage its relationships with the provinces, the 9 provinces in South Africa, which are so important in terms of service delivery. Provincial governors are, by and large, political appointees, and so are the people they appoint to manage health affairs in provinces, and you see decidedly mixed results from that system. So there's a long list of problems. I could carry on, but I won't. Now, the point of talking you through this laundry list is to belabor the point that PEPFAR, in implementing this new global strategy, in arguably its most important country partner, is not operating in a vacuum here. It has to navigate complex, difficult economic and political currents. So it should come as no surprise, therefore, that this has been a difficult environment in which to implement a new strategy, and that the changes triggered by the so-called pivot have been at times jarring for the host government, a government that is quite preoccupied and inward-looking at the moment. Now, the PEPFAR pivot was well underway during our visit. As you're all aware, and I probably don't need to go into much detail here, the pivot's all about allocating limited resources in the smartest way possible by targeting the populations and locations that drive HIV transmission. And it's prompted major changes to how and where programs are run in South Africa. The data supports PEPFAR's more strategic approach. In South Africa, there are 52 health districts, but more than 80% of people living with HIV live in 27 of those districts. And while there was some initial pushback against the new strategy from the South Africans, the government, I think now, is, at the national level at least, is on board with the strategy. I think it also helped, and we saw this and heard this in our meetings, that PEPFAR's strategy is amplified and echoed by other key donors, such as the Global Fund, and that it's using as its reference point the 1990 targets set by UN AIDS. The tough part, though, of course, is implementing the plan and shifting the resources, the personnel, the partners at the district level, which is really low capacity. It involves scaling up services in 27 districts, slowly withdrawing them in 25 others. PEPFAR and the South African government have each helped each health district set up an implementation plan, but inevitably there's been some upheaval. The PEPFAR country team was confident they'd managed to limit this upheaval. They were affecting the smooth withdrawal of PEPFAR-supported services at more than almost 4,000 sites. That was due to happen by the end of 2015. And that's a lot of change to absorb in 4 short months since the rollout began. And I think it's going to be very, very important to monitor those communities affected for a long time to come. Ultimately, I think focus for impact in South Africa is going to stand or fall on the ability of PEPFAR in South Africa to gather good quality data, really granular, disaggregated data in real time or as close to real time as possible, and respond to that data as well to make sure that gaps are filled. In terms of PEPFAR's work with key populations, we were in South Africa just as the DREAMS partnership was being rolled out. DREAMS in South Africa will, as many of you know, provide combinations of assistance, biomedical, behavioral, social, economic, to the vulnerable young women and adolescent girls group that I mentioned before. When we were there, it's too early to see the programs up close and personal. They were still being introduced, but we did see some of the planning that went into the effort. And I think one of the things that we were most positive about was that clearly the work that DREAMS is undertaking in South Africa, at least, has been matched by complementary efforts by the Global Fund, by the German government, to name another important donor, and most importantly by the South African government themselves. So this will allow the potential for some of the activities underway in the DREAMS districts, or actually they're just 5 sub-districts, to be tried and tested and potentially scaled up and complemented with other activities. I think the targets are incredibly high and ambitious, and we need to set our expectations accordingly. But certainly, at least in the planning process that we saw, there was a lot to be encouraged about. Now, you'll see by flicking through the report that we may make a fairly lengthy list of recommendations. I'm not going to go through them all, but maybe just to cite a little selection. I think it's going to be incredibly important as the US thinks about its future engagement in South Africa, is that engaging on the inequality agenda at all levels will have to be a priority. Inequality, whether economic, social, health inequality, is really perhaps the single biggest challenge that South Africa faces, and it undercuts progress in all sectors. South Africa's plans for universal health coverage, I think, have been met by a degree of skepticism by the United States, but I think the US has no alternative but to try and engage in that process and try and see how it can be rolled out in a sensible, incremental way. Promoting dialogue between the government and the private sector struck us as something that the US could play a useful role in. There's still this slightly distrustful attitude that we encountered from members of the government towards the private sector, a feeling, and justifiably so perhaps, that at least in recent years, as the private sector has gone through its own struggles, it's withdrawn from some of the leadership it previously showed in responding effectively to HIV/AIDS. For PEPFAR in particular, I think something that came across to us in so many of our meetings was the need to keep disruptive, fast-paced transitions to a minimum. Of course, PEPFAR is an evolving relationship that's gone through different stages. But we heard firsthand from, just to give you one example, a Catholic bishop who recounted the story of a previous transition that left his HIV hospice no longer receiving PEPFAR support, and the arduous, long, tortuous process of negotiation that triggered with the local provincial government to try and get that funding filled. Often you get these imperfect arrangements that are the final output of these discussions, where funding might be partial or it might be short-term. These are very, very tiring processes. They're disruptive, and of course, ultimately, they're unsettling for patients. And finally, I think the need for a holistic approach to HIV. I mean, it's easy to roll out holistic recommendations and talk about health system strengthening, but really, it's so central to the situation in South Africa. We can applaud the progress that South Africa has made in the battle against HIV, and we should do. But they're fragile gains when other health indicators are heading in the wrong direction, when you have non-communicable diseases on the rise, mental health problems, MDR, TB, for example. And it's not just a case of throwing more resources at the situation. Inefficient bureaucracies, poor management, the lack of policy follow-through. These are all issues and problems that affect South Africa's ability to meet its health burden. To close, I just very briefly want to take a quick look ahead at some of the things that we see on the horizon as being important to monitor as we further analyze the US-South Africa health relationship. The first, of course, is the 21st International AIDS Conference in Durban, and I'll leave our panelists to give their thoughts on the opportunities that provides. The rollout of universal test and treat from September, I think, will be an important moment for South Africa as well. It was announced just last month, a significant commitment but a rollout that's not without risks. The health system will have obviously an added burden that increased caseload of people receiving ART will entail. There are financial implications, but can the system, can the supply chain, can the drugs procurement systems keep up with this? Will there be strong commitment to keep adherence clubs strengthened so that people have the support that they need when they start this treatment? Finally, as well, the ongoing drought in Southern Africa and South Africa, I think, will demand close attention. After this trip, after this event, I'm getting straight on a plane to Mozambique and Malawi to look at this issue particularly, and it's having a devastating effect in South Africa. And we know from previous drought situations that this causes a lot of problems for the most vulnerable people. If you're not getting adequate nutrition, access to water, that can have knock-on impacts on your ability to adhere to ART, for example. So I think PEPFAR will, and is, I know already, thinking about its response and how to be flexible in limiting the impact of the drought. And just one final word, and that's to bring things back to politics, because I think they're so important in the South Africa context. There are municipal elections coming up in August, and they're an important moment for South Africa, and most likely going to be a very difficult test for the ANC. I think they'll provide a strong indication of the public mood towards the ANC. It's been hard to ignore the decline in governance over the past few years and the growing dissatisfaction among the public, particularly centered on the quality and standard of service delivery. So how the ANC reacts to these results, whether positive or negative, will have big implications to watch going forward. I've already spoken for far too long. You can read the report, and I appreciate your feedback. And with that, I want to invite our panelists up to the platform, and we'll go into a more interactive discussion from there. Thank you very much.
Thank you, Richard, for that overview of the report, and we'll have the opportunity after our panel discussion for a Q&A, and Richard would be happy to answer any questions that you might have. Let me take the opportunity now to introduce our panelists. First, we have Regan Hoffman. She's an internationally recognized authority on HIV/AIDS. She serves as policy officer in UNAIDS U.S. Liaison Office here in Washington, where she works to build stronger, more strategic collaborations with the executive branch of the U.S. government to support the global response to HIV. Ms. Hoffman, who has been HIV positive since 1996, is an activist, global health consultant, award-winning journalist, and a published author. Leveraging her background in publishing, TV media, and advertising, she has become an articulate and persuasive advocate for HIV/AIDS and helped to increase the visibility of the HIV pandemic. Next is Dr. Jen Cates. She is Vice President and Director of Global Health and HIV Policy here at the Kaiser Family Foundation, where she oversees the foundation's policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemics. She's widely regarded as an expert in the field and regularly publishes and presents on global health and HIV policy issues, and is particularly known for her work analyzing donor government investments in global health, assessing and mapping the U.S. government's global health programs, and tracking key trends in the HIV epidemic, an area she has been working in for 25 years. Third, we have Dr. Nemande Nolochungu, the health attaché at the South African Embassy here in Washington. She represents South Africa's health department in strategic dialogue and foreign policy engagements with the U.S. government. Dr. Nolochungu is the former head of health in Gauteng province, South Africa's largest province by population. Previously, she served as chief director of the HIV/AIDS unit at the National Department of Health, where she led the progress and process to write the National HIV and STI Strategic Plan for 2007-2011. And finally, we're joined by Cornelius Baker. He is Chief Policy Officer at the Office of the U.S. Global AIDS Coordinator and Health Diplomacy at the U.S. Department of State. He has been a committed civil rights and HIV/AIDS advocate at the local and national level for over 2 decades. His experience in government includes appointments at the U.S. Department of Health and Human Services under President George H.W. Bush, and as an aide to Washington, D.C. City Councilwoman Carol Schwartz. Mr. Baker currently serves on the boards of the Black AIDS Institute, Public Responsibility in Medicine and Research, Broadway Cares Equity Fights AIDS, U.S. Helping Us, People into Living, and the Executive Committee of the Forum for Collaborative Research on AIDS. So thank you and welcome to our panelists. And let me turn to Ms. Hoffman to offer some remarks on the UNAIDS, the UNGAS, the panel last week, and your recent trip to South Africa.
Great, thank you. Great, okay. Good afternoon, and thank you to CSIS and Kaiser for having me here with you today, and also Gates for supporting this event. I'll just give a little brief recap of the HLM, which happened last week. The HLM is the high-level meeting on ending HIV/AIDS, which has happened every 5 years for the last 15. And we met in New York last week, convened by the President of the General Assembly, and it was co-facilitated by Switzerland and Zambia. And it gathered heads of state, ministers, and people from all around the world to just basically map out the next 5 years of the action plan for ending AIDS. As we all know in this room, and as we work on, we know what we need to do. So the HLM's goal was to come up with a political declaration that could articulate specifically what we do next and put it into the most specific terms possible. So the negotiations happened for several weeks, and the goal was to produce a political declaration that could be adopted by the member states and give people a way forward. Nothing terribly surprising in the political declaration. I think it's quite complete. It really touches on all of the critical areas. It includes time-bound specific targets, including the 90-90-90 treatment target. It really references all of the different aspects of the disease response that need to be addressed. There's always controversy around the HLM. This year was no exception. And I think the main conversations were really around inclusion. We talk about stigma and discrimination, we talk about the need to reach everybody, but how are we going to do it? We've done the easy stuff. It wasn't easy, but what we have to do now is increasingly difficult. So the conversation really focused on key populations and young women and girls at risk, the people who are hardest to reach, and how do we get there with the resources that we have. Other themes of the meeting obviously included who's going to pay for it, private sector involvement, the science and translating that into the field. Getting pills into people and getting prevention to people is one thing theoretically, another thing on the ground. And I think in the end, there were some really great conversations, some great side events that also happened, and we focused on a couple of key themes, which all of this is actually on the HLM website. It's HLM 2016, and I can send the link out to everybody. But at the end, we made a couple of announcements that I think really characterize this moment. One, UNAIDS data shows that 17 million people living with HIV are now on treatment, which is astounding. The last political declaration called for 15 million on treatment by 2015. That goal was met 8 months ahead of schedule, rare for a UN goal to be met ahead of schedule, but it was. And now we're looking at 17 million people on treatment. But as wonderful as that is, as you all have pointed out, we're not really even quite 50% of the way there. So the work left to be done is staggering. The scale of the problem, enormous. This remains a global health catastrophe. And for all of the conversations about the potential we have to end AIDS, there is increased urgency and increased agitation around how we actually get it done and whether or not we'll get it done. We've made great progress against elimination of mother-to-child transmission. There was a special event focused on the global plan and the progress made against the global plan. And there was an announcement made that in addition to Cuba, Thailand, Armenia, and Belarus are also now verified as countries that have virtually eliminated mother-to-child transmission. So that's a huge step in the right direction, massive progress made against transmission of mother-to-child transmission, but still a lot of work left to be done and still a lot of children not yet being cared for. I think if I took one thing away from the meeting, it was something that I saw in South Africa a month ago when I was there with some members of Congressional offices as well, which is this moment is really encouraging, but it is also incredibly daunting. And standing in a township in South Africa, having seen remarkable progress in one area, we look out at this country and see 3 million more people not in care. And we see people on the ground tapped out, really, truly doing extraordinary work. One doctor in a clinic treating 15,000 people a month. How do we ask people to do more? I thought I would just make a couple of points about what I saw on the ground in South Africa. Richard laid out so beautifully the challenges. Maybe I'll highlight some of the things that I thought were exciting. I'm always the optimist as a woman living with HIV. I have to believe we can get this done, right? So first thing is we actually can do more with the systems and people in place. 2 examples. One, the program that is using nurses to initiate treatment for people, not depending on doctors anymore, to give people their first connection to treatment. Program's going incredibly well, nurses being incredibly successful at converting people to being on treatment and doing quite a good job of helping them to adhere. In a voluntary medical male circumcision clinic, the young women counseling the men who were getting circumcised there took it upon themselves to address gender-based violence. It's interesting, some of the young men preferred, there are 2 basic types of circumcision. One is the more traditional with a scalpel and they cut the foreskin off. Another is using a compression device that allows the foreskin to fall off over time. And the younger men wanted to be cut. They wanted to be a man. They wanted to bleed and have the pain. And this also read into the notion of these men wanting to sort of conquer women. And the counselors there were hearing these attitudes in the young men and thought that this was a good chance to perhaps talk to them about their attitudes towards women and girls as they were entering adulthood. So there's a whole gender-based violence counseling program integrated into this clinic. We also saw the use of technology and private sector engagement really amplifying the work that was being done. So a program set up using an SMS platform to help pregnant women adhere to treatment. Allowed these women to be agents of their own quality of care and to be able to report directly on stockouts, on nurses who were good, nurses who were bad, and really give a portal to patients to respond in real time on the ground to what was happening, so that the hospitals and the healthcare workers could get that immediate feedback and respond immediately to needs and concerns, and also to amplify the good work that was being done. As Richard said, I think the thing that struck me the most is we are doing all of this work in an incredibly complex environment, and people live in challenging worlds with a hierarchy of needs that doesn't always mean that HIV is their first concern, even if they're living with it. And so I think systems and responses that focus on the whole person and treat people as people and give them the support they need throughout the course of their life to deal with this disease is critical. And then, of course, the leadership of the government there, and transitioning from having a lot of external help to taking on this problem themselves, owning it, while still continuing to give due course and support to those who are helping them. I'm watching that transition. AIDS will be obviously incredibly pivotal in the upcoming elections in South Africa. It will be, and I'm sure others here know much more about this, an issue that really shapes the political climate this fall. So I think that people are aware of that. And as we look towards Durban, I think it's a remarkable opportunity to do a couple of things. Obviously, to connect what is happening on the ground to the people who are going to be focusing on this issue at the highest political levels at that time, and to help people understand, I think that there's an opportunity to use groups of people who are not being leveraged, I think, as well as we can. People living with HIV, civil society, faith-based organizations, I think, bringing in private sector, I think really there are a lot of people out there who want to help, and we can't just focus on the medical systems, the health systems. We have to look at the totality of what's happening. Bless you. Last comment. I think for me it was crystallized, the moment that we're in was crystallized by being in a clinic where in one part of this clinic we were holding a woman who she was probably 65 or 70 pounds, had Kaposi sarcoma, and had come in presented with about 15 T cells in 2016. And then we walked through the clinic, the hospital. And in another part of the hospital, they had a prototype of a machine that was an automated dispensary for ARVs that would allow people to dispense medicine to many, many more people, and including an ATM machine that people could actually present a card in and get their medicines themselves, a great way to get around stigma. You have a woman dying of AIDS, and you have a machine that can give people their medicines with a card. And to me, that's the gap that we have to close. But it's so urgent. I mean, I know I'm preaching to the converted in this room, but 20 million people are waiting, and we put targets and timetables out there in policy that suit election cycles and meeting schedules, but 20 million people are on the brink of illness and death. And I think bringing the urgency back into this moment would be extremely helpful. And I think Durban has the potential to absolutely do that and to reignite the global conversation and make people aware of the whole context in which we operate and the total scale of need and the dire urgency with which we need to respond.
Thank you, Regan. And I think that's a perfect transition now. Turn it over to Dr. Cates, who's going to offer some reflections on Durban and what that offers for all of us in the community.
Sure. Thank you, Sarah, and thanks to CSIS for asking me to be part of this. As soon as I read Richard's report, I knew this would be a really important opportunity to talk about what's happening in South Africa. But I just have to say, like probably many of you here, I'm still a little rattled by what happened in Orlando, and so my mind is in a couple different places right now. But all of this is also connected to our ongoing fight in HIV to fight stigma and hatred, and so I think we can just remember that for a minute. So I was asked to provide some thoughts on the sort of connection of the Durban conference that's coming up to the original Durban conference in 2000, what it means, what can we take away, and what could we expect. So I'm going to start with a little bit about the International AIDS Conference as a platform and kind of what it's meant as part of the fight against HIV. I think it's easy to sort of see those as conferences, right? We all go to conferences, and some are better than others in general, but I think this conference has had a very different role in that it has become part of the fabric of the HIV response, and it both reflects the response at different moments in time and has contributed to it. The conferences themselves started in 1985, originally more as a scientific endeavor when the science was new and the situation was quite dire. But quickly, as with everything with HIV, you can't separate politics from science, and it quickly exploded into a scientific and political challenge. And that one of the first big issues that came up was the travel ban, preventing people with HIV from traveling to certain countries, including this country, and resulting in the AIDS conference, which occurred in San Francisco in 1990, not coming back to the United States until 2012, after the lifting finally of the travel ban here. So it's always had this kind of very intense political essence to it. And it's also had moments of hope, and I call back to the Vancouver conference in 1996, when combination antiretroviral therapy first was sort of debuted as a global success, and what followed quickly in developed countries was access to antiretrovirals and death rates beginning to fall in very dramatic ways. So Durban, I think, Durban 2000 needs to be seen in this longer trajectory. And I'm actually really curious, who here went to the 2000 conference? Okay. I see maybe like two hands. I went. All right. So there's really very little of us. Okay. So then I feel okay about saying the various things. I'm giving you a little bit of history here, because I think it's really important to remember what was happening in July 2000 when this conference took place in South Africa, in Durban. What's important to remember that this moment was pre-UNGAS. It was pre the 2001 special session that was at the UN for the first time ever on HIV. It was pre the WHO 3x5. It was pre the Global Fund, pre PEPFAR. Basically, it was a completely different era than we're in now. And for those who might not have been engaged in HIV yet, the number of people on antiretrovirals at that point in the developed world, particularly in sub-Saharan Africa, was negligible. I mean, very few. Those who could afford it, basically. That was it. And there was actually a debate about whether you could scale up antiretroviral therapy in the developing world. There was a debate. It ranged from whether it was too costly. Several donors actually were on record being concerned about it being too costly. There were also, or not cost effective. There were other things that were more cost effective was part of the argument. There was questions about, well, if you can only scale up in certain places, was that ethical? And then, of course, there were other more maybe nefarious views around, well, we can't really do this in Africa where people can't tell time. There were actually things like that said, but this was a real debate. There was a debate in donor capitals. It was a debate at the World Bank. It was a debate in places that now are, have helped to turn this around. But this was really where this conversation was. And within South Africa, as has been alluded to, at the highest level of government, the president was actually questioning the link between HIV and AIDS and questioning whether antiretrovirals were good for people. So this was the context. So from any perspective, if you presented that to somebody, a student of history, you would say, do you think that we actually scaled up to 17 million people around the world and 3 million? No, the forces were conspiring against this, and that really was what it felt like. But it is within this context that Durban happened. And I think Durban helped to turn this around. It wasn't the only thing, but it really was a moment. It was the first international AIDS conference held in Africa. It was important that it was in South Africa because South Africa, for many, many reasons, is the bellwether, the leader on any issue in sub-Saharan Africa. And so if South Africa can do this, that would give a lot of hope to the rest of the continent. It brought together 12,000 activists, scientists, researchers, and it highlighted this very real issue about, it basically made the case that it was unethical for the developed world to have access to antiretrovirals and the developing world not to. And that was the case that was made. It took on the issue of HIV denialism by creating the Durban Declaration, which was an actual statement that went on to explain how HIV caused AIDS, and it was signed by over 5,000 scientists and released at this meeting. That was actually needed. It was published in the journal Nature. I mean, this was what was happening at that moment. So I really, having been there and watching this unfold, and I give a lot of credit to activists who were on the street making this case and demanding that treatment be provided, it worked. I think the HIV epidemic has been different ever since. You can't underestimate the value of showing people in real time on the ground what people's lives are like when they don't have access to care, treatment, and prevention. But we can talk about prevention as well, because I think that's sort of always been left to the side, and we should come back to that. South Africa's own treatment program, then following the announcement of the Global Fund being created and PEPFAR, South Africa's own treatment program was announced in 2003 and rolled out in 2004, largely funded by PEPFAR. The country first began the public sector treatment rollout in 2004. So it's quite amazing that given all of this, we are where we are, but with 50% of South Africans who need treatment on treatment. As the CSIS report has showed, you should look at the charts showing the dramatic decline in AIDS deaths, dramatic decline in number of new infections as the scale up to antiretrovirals has occurred. And it's the largest treatment program in the world. So I think this is quite a success. It's a success for South Africa. It's a success for PEPFAR, for the Global Fund, and really for the global community. A story that I hope we can tell for other things going forward, but I'm not sure. And as it was said last week at the high-level meeting, for the first time ever, the number of people in Africa going on to treatment, who need treatment, is greater than the number initiating treatment is greater than the number of new infections. And that's the really important point that we need to be at. But as with the HIV response everywhere, there are challenges. We've heard a lot about them. I think the conference itself has a different role today than it used to. But I do think when you bring people together, that many people, and it will be at least that, or maybe it will be bigger than the Durban 2000, it has not just the potential, but it really does shine a spotlight on what is happening on the ground. And that's what the opportunity is. It certainly can't be separated from the high-level meeting and all of the other things that will follow, but it really, I think, is an important opportunity that we should seize on to show what still needs to be done, both what has been done, but what still needs to be done. And I think time will tell. At Kaiser, we're pulling together a webinar next week to look at what's going to happen at the conference itself, what the theme is, what the science is likely to be, what the controversies may be. It's on the 21st at 10 a.m., so it's open to everybody who might be interested in listening. We actually have Chris Collins from UNAIDS is going to talk about civil society engagement in the conference. Chris Byrer from IAS is going to talk about the conference itself. Linda Gale Becker is going to talk about the science. So it'll be an opportunity not to talk about South Africa only, but really the conference significance. So I encourage you to participate in that. But I'm also an optimist, and I hope that we can use Durban as opportunity of bringing many of us together to really forge ahead. Thanks.
Thank you. Now let me turn to Dr. Nolotshungu, who to offer some reflections from the South Africa perspective.
Thank you, Sarah. As mentioned previously, we're meeting in a cloudy moment, with what has happened in the past 48 hours in Orlando. And in a South African way, I would really indulge me, Sarah, for people to just stand and observe 5 seconds of silence in solidarity with people who have been affected by what has happened in Orlando. Thank you. So we're pleased that the CSIS takes interest in what South Africa does in the health sector, specifically in the area of HIV and AIDS. And in fact, the work that has been done by the CSIS has informed and influenced the policies in the health sector between South Africa and the US. Recently, we have seen improvements, quantitative improvements in the budgetary trajectory by PEPFAR, informed by reports of the work that has been done by the CSIS. So this is work that we value and support ourselves. When they do the trips to South Africa, the embassy here makes sure that they meet with strategically important people to inform what is happening in South Africa, so that when they come back here, and as they inform policy directions on how best to interact with our country, they are informed at that level. We refer to AIDS 2000, a catalytic moment indeed in the AIDS environment. It is a turning point. It was a turning point. It changed things in relation to global denialism. Yes, there was a denialism in South Africa, but it was also a global kind of phenomenon where drugs were not affordable. Pharmaceutical industries were developing drugs, but the drugs couldn't be delivered to people who needed the drugs. There was denialism in the policy space from the government perspective. There was denialism also in the funding space, because the most affected countries couldn't afford these things. So the catalytic role of Durban 2000 was delivering on those issues. On the UN coming up with the first political declaration, informed by what had happened in Durban and previously, obviously. We saw the establishment of the Global Fund, and South Africa was an important element of the establishment of that fund. Initially, in fact, the Global Fund was saying we're going to be just focusing on HIV, and South Africa said no. Most of the people that actually are HIV positive in South Africa are dying from TB. So we'd like to see this thing expanded to include diseases like TB and malaria. That is how we came with a global fund that now covers HIV, TB, and malaria in South Africa's influence, based on its experiences. So yes, Durban 2000 did break the silence. That was the theme of that conference at the time. From where I sit, I have faith in ourselves in being able to do those things from different perspectives. Many of the speakers before me have actually cited what has happened since Durban 2000, especially in South Africa. I've just come back from the HLM that you referred to, and the report that is coming true in an unequivocal way is that the world has delivered on the political declaration of 2011, which I had the privilege of negotiating on behalf of South Africa from Washington. The world has actually delivered also on MDG 6 because we all work together in partnerships, catalyzed by Durban 2000. If you look specifically at what the African continent has done in terms of that delivery, it being the epicenter of the epidemic, in terms of numbers now, proportionately and quantitatively, most of those numbers are coming from the African continent. African continent led the success on the delivery of the 2011 political declaration and MDG 6. It shouldn't be, there shouldn't be no doubt now that Africa can actually do these things. South Africa has the abundance of the conditions and the drivers of the HIV and AIDS epidemic, abundance of civil society that is active in terms of the fight against HIV, abundance of professionals and researchers who are educated on the disease, abundance of research and development infrastructure. If you look at the budget of the NIH, most of it, a big substance or proportion of the NHA budget actually goes to South Africa because they have confidence in what that country can deliver in terms of research and development. So we maximized on that abundance. Not all of that abundance is good. We don't like that we have the highest number of people who have HIV. But at this point, we're proud to say that we actually have the largest treatment program now with about 3.4 million, in fact, at this point now, people on antiretroviral therapy. You mentioned NIMAT that you came across at one of our clinics. That's the nurse-initiated and managed antiretroviral therapy program. We took a painful decision to say, if we don't have enough doctors at our clinics and we need for people to get access to treatment, what are the things that we can do outside of the box? Should we wait until we train enough doctors to be able to initiate treatment? That was not an option. So we took the NIMAT program, piloted it in one of the districts in the Free State, in the province called Free State Province, saw the results in that evidence from that it can be done, and it didn't decrease the quality of the standard of the care in the country. It was expanded, it was made national policy. And we're proud to say now we can do NIMAT everywhere in the country. And that actually contributed to us getting to the point of 3.5 million people on antiretroviral therapy. One of my panelist colleagues indicated that we've dropped transmission of mother to child of HIV from what it used to be in the early 2000s, in the region of about 20–25%, to a whooping 1.5% now. Programs on the ground bearing results. Kids now in the age group between 0 and 15 have been bared the burden of having to live with HIV. Medical male circumcision is widely practiced in the country. Even in traditional communities where circumcision was not part of the tradition, you basically bend the rules and talk to the traditional leaders and make them understand the need to go through some of the things that need to be done. So traditional leaders and the king of KwaZulu-Natal province, where you don't have a traditional male circumcision being practiced, bends the rules. Culture can be changed. South Africa has demonstrated that through the implementation of male circumcision, especially in KwaZulu-Natal province. So, as we move to AIDS 2016, returning to Durban, We're expecting about 22,000 people to converge into South Africa in the Zulu Kingdom, where we bended the rules on traditional circumcision and other things, where we did phylogenetic studies to find exactly what are the sexual social networks that drive the infection amongst young women and adolescents in the country. We now know that, in fact, young girls in the age group between 15 to 24 get infected by men who are about 5 years younger older than they are. We had always thought it was this thing about older men preying on younger girls, but the gap is not that big based on the phylogenetic studies that we have done in the country. So that abundance of science and knowledge has informed how we target interventions there. That information will also be shared at the 2016 AIDS conference to be happening soon in South Africa. I was actually at that conference. It was my first year working in the AIDS program in Gauteng province, where I was a director of the program, where we started with the prevention of mother-to-child transmission. When the cost of drugs came down, we were the first province, even ahead of the national department, to announce that we will actually be providing treatment to people in this particular province. And the province relied on people like ourselves to go to the ground, make sure people are trained, the drugs are available, the systems are in place, information systems are in place, the communities are educated, and everyone is ready basically to implement. So the premier of the province could announce, he had confidence in the system, and could announce ahead of the national policy level that this province will actually provide treatment for people in Gauteng province. When we go back, as we return to Durban, President Mandela won't be there. Madiba is no longer, but we know Madiba lives spiritually and in the fabric, in the DNA of that country. We know his role in the fight against HIV in the country. The speech that he gave at the Durban 2000 conference remains etched in the books of Durban 2000. Nkosi Johnson, the young boy who spoke in Durban, where he is, he's probably looking and saying he's proud of what he managed to do, catalyzing the provision of treatment, prevention of mother-to-child, and treatment, early treatment of infants in the country. All of that has changed now. The flavor is totally different. Judge Edwin Cameron will be speaking. He gave the Jonathan Mann lecture. He was one of the people who could afford to get treatment for himself at the time. He'll be telling a totally different story now. I don't think that we should forget the role of Jonathan Mann globally as the first director of the WHO AIDS program in the world, and his thinking about what should be done about this epidemic. I believe in the saying, there's nothing new under the sun. Really, there's nothing new under the sun. If we go back to what Jonathan Mann has been saying about this epidemic, there's a few things that we can learn from that. So I'm happy that Judge Edwin Cameron will be there to give the Jonathan Mann lecture in 2016. 2016, returning to Durban, has to deliver on effective prevention. It has to deliver a clear road to an effective vaccine. hope for closing the tap. It has to deliver on what it is that can be done towards finding a functional cure. And in this regard, I'm happy to see that Anthony Fauci will actually be leading the discussions on finding a functional cure, and that the NIH is funding all of the work towards the development of a functional cure. We shouldn't be afraid talking about vaccines and towards finding a cure for HIV. That's the ultimate, that's the effective prevention. Of course, there are a lot of things that we can do whilst we're on the road getting there. Access to medicines. If we're going to be implementing PrEP, if we're going to be implementing test and treat, which is what South Africa has committed to do by way of policy and funding, the thing about monitoring antimicrobial resistance is going to be key. We've had bad experiences with TB and the development of multi-drug resistant TB for various reasons. And we should be learning lessons from that. So as we go to Durban 2016, we all agree that PrEP should be implemented. Test and treat should be implemented, but within an environment that has learned lessons from TB and MDR TB development, so that we have systems in place to make sure that we don't end up in a place where we have all of these problems. So,
Dr. Noluchumu, could I just ask you to wrap up just for a moment?
Yes.
So I want to allow time for Q&A. Yes,
got you. 2016 is about access, equity rights now. Reaching people who lack access, have to deal with stigma and discrimination. This fear that is driven by lack of information, poor access to services, discrimination, that thing has got to go away. And if 2016 delivered on anything, in my view, is basically that we have to deal a dent with fear-driven kind of perspectives on HIV and AIDS. So access and equity rights now should be a reality as we go to 2016. Thank you.
Thank you very much. Let me now turn to Mr. Baker, who's going to offer reflections on the U.S. government's view.
Great. Thank you very much for having me here, and also to Kaiser for hosting us here in this space. I'm not going to talk very long, in part, as Jen has already mentioned, and as the Honorable Attaché has mentioned, it's such an emotional day. My family is from Orlando, and we spent most of the day yesterday making sure that none of my cousins were at the club, because it's one that we frequent along with a couple other gay clubs there, Southern Nights and Parliament House, and fortunately they weren't. And but I think it's a moment of reflection, in that when we think about the high-level meeting last week and the difficulty just having member states recognize the basic humanity of gay and lesbian people, and to have a moment like yesterday where that humanity is made plain to us, and that we now, unfortunately, in a moment of great suffering, recognize it, much as we did in 2000 when we went to Durban. And Jen was very polite about what it was, and I think that, you know, it's important to recognize that in 1996, the HIV cocktail, the strategy of drug treatment, was unveiled. And then the following conference was in Geneva. And we were having this conversation about people in the wealthy North having access to life-saving drugs, while millions of people in the South were dying. And the decision to go to Durban was a moral one. It was about we can't separate ourselves. And so we had to go to Durban for the conference. And what we were confronted with was the humanity of people who simply wanted to live. A lot of that was led by Treatment Action Coalition, the National Association of People with AIDS, people like Justice Cameron, Zaki Ahmed, and other people who were activists demanding that the death and the suffering not remain invisible to the rest of the world. As we return to Durban, this concept of who we are as people, we clearly have the science on our side at this point. That we have treatment and we have prevention and we do not have a vaccine and a cure, but we have what we need to significantly change the course of the epidemic. And as we return to Durban, the real question is, do we recognize the humanity of all of those in need? And will we stand with the activists and the organizations that have been so much a part of the response? Any of you who have heard Ambassador Burke speak, you know that the role of civil society is very much at the forefront of her thinking. In part because it is the only way that we're going to end the epidemic. That science and government are important parts of the equation, but HIV happens in communities, and it happens among people. And those communities and those people have to be empowered to be part of the solution. And we are at a tremendous time right now as we go to South Africa, where civil society's voice is very much present, but it is struggling. It's struggling for resources, it's struggling for attention, and it's struggling to be respected. So for us, the engagement of civil society in everything that we do is important for the sustainability of the HIV response. As we go to Durban, and the report highlights our work in dreams, in the past, a large part of the attention on the epidemic has been on key populations of gay men, of people who use drugs, of sex workers, and of transgender populations globally, which all continue to have a burden of disease relative to the general population that is simply unacceptable. But when we look at Southern Africa, and when we look at the epidemic, our heart breaks for the lives of young girls and women and their circumstance. And we have to be very bold, and we have to be visionary in thinking about the life of the girl. Making sure, we use very polite terms like gender-based violence. It's rape. Many of these girls are being raped, and it is simply not acceptable. And we have to begin to call out this forced sex. And some of the girls are raped, and others are forced into a circumstance economically because they cannot go to school, no one will pay their fees, or they're not respected to get an education and to be able to have a better life. And so that man who's 5 years older is a source of income. And that in itself is a violation of her dignity and of her rights. And we have to begin to look at how does our prevention program, how does all of our work in HIV help to elevate the life of that girl. And then lastly, we have to think about, and I know that the report mentions the difficult transitions that we've had in PEPFAR over the last year and a half in the PEPFAR 3.0, which is more than just a resource reallocation. It's a fundamental way in which we change our way of doing business, from the engagement of civil society, for transparency, putting everything on the website, making sure that we're fully engaged in our response. But it is also a resource allocation decision that we, one, cannot do everything, but we also need to make sure that we're looking at where the burden of disease is and that we're putting our resources where we can make impact. And, you know, this isn't new, just the PEPFAR. In the United States, we did this about 10 years ago with our prevention funding. And we moved money from North Dakota, we moved money from Minnesota, we moved money from South Dakota, Iowa. We moved money from where there was not huge burden of disease. And we began moving that money to Mississippi and to Alabama. And because that's just. And we know that health systems are fragile and that a large part of public health has been able to sustain itself because of HIV funds. But we have a mission to end the epidemic. And we have to put every dollar, every dime, where the epidemic is. And those are very hard decisions. We hope we only have to do it once, and then really, really have impact. And that requires a lot of political will. And I guess that's where I'd like to sort of end my comment, that all of what we've done for the pivot required political will, but everything that we need to do by 2030 is going to require enormous will. It's not just about the science anymore. The science is clear, the science is plain. Do we have the will to do it? Do we have the will to treat all? Do we have the will to do the type of prevention programs that will serve not only those key populations, but also new innovations that respect the life of the girl? Those are the real choices before us. And those are the things that, as we go back to Durban, that we're going to have foremost in our conversation. I think that we can do this. Ambassador Burke certainly believes that we can do it. And because of the generosity of the American people, we've made enormous strides towards being able to change the course of an epidemic. And now we have to have the will to end it in our lifetime. And I know that each of you are committed to that, and we thank you for the partnership.
All right. Thank you to all of our panelists for their remarks. And we'll open it up to questions now. We have about 40 minutes, so I think we'll take several rounds. We'll start with 3 questions and then do some answers and follow up. So I see first a hand in the back there, one over here, and then one in the front.
Hi, my name is Pamela Pine, and I'm here representing Humana People to People. We're a worldwide consortium working on health, agriculture, and education. I'm also, as a side piece, representing another group, actually not representing, but I'm going to go ahead and talk about them anyway, which focuses on child sexual abuse. And I thank you, by the way, for your comments on GBV and rape, which is what it is. It's rape. We just don't want to call it rape. But I'd like to talk also about the percentage or proportion of girls that are being raped, but not necessarily, but people outside of the home or outside of their community, and the impact that that has on HIV and AIDS, and whether we as a community can start addressing child sexual abuse as the problem that it is within societies throughout the world and its impact on HIV.
Okay, thank you. Okay, there was a hand up over here. Go ahead.
David Brodden with Results. Thanks for the really fascinating report and for the panel and the discussion. I'm wondering if you could comment on 2 things. Looking at HIV stigma and the stigma and discrimination that people living with HIV suffer. It's interesting, there's a survey that was done recently in South Africa about that phenomenon, and people living with HIV reported that if they were to be sworn at or insulted, it was much more likely actually that they would be, that would occur to them because of their perceived tuberculosis status rather than their sexual orientation. So when we look at South Africa, it's a very particular phenomenon that's going on in high burden TB HIV settings, and so that stigma issue is really intertwined actually, TB and HIV, and needs some particular attention. So I want to know if, Richard Downey, if you could amplify on any of your findings in your trip on TB in particular, and particularly if we look at it as a regional problem. Because South Africa has its own problems, but there's a migratory labor situation going on with Mozambique and other surrounding countries, and you could look at that as a key population, minors, and also with regard to TB HIV prisoners.
Great, thank you. Go ahead.
Thank you very much. Fascinating. Lynn Lackey, Johns Hopkins University School of Public Health. I've worked in Swaziland since 2002. Highest rate of infection in the world, another way of defining burden. Many of the similarities, shared issues with South Africa, of course. I hope you'll visit Swaziland when you travel there. Would just like to make a few comments. I've just recently returned from Swaziland, and people, of course, talk a lot about the conference. They're very close to Durban. I solicit all of your assistance in talking with the organizers of the meeting. People cannot afford to go to these conferences. The young women we're talking about who should be there, whose voices need to be there, will they be able to come in the door? The conferences are great, they're inspiring, they're energizing, but we need this dialogue between the stakeholders and the scientists, quote unquote, and you can tell where I'm from. I'm not anti-scientist at all. But the conferences have traditionally been organized, sort of the community in one room, the scientists in another room, and you can't cross from the free public access area into the science area without paying lots of money. The scientists need to hear what's going on in that other room, and those voices need to be in the scientific presentations. There are university students who are the leaders of tomorrow. They can't afford to go. They barely have enough money to pay for petrol to drive to Durban. They might stay with friends down there. But the issue of dialogue, and Richard Downey, I think, was very gentle when he talked about the pivot and how people feel. People expressed to me that, yes, we understand there may be less money, there may be flatlining, but please consult with us. We're in the middle of a generalized epidemic here. And when you say we have to narrow this to certain groups, let us at least help with that process. So very glad we're beginning to see key populations, young women, 16 to 24-year-olds. We've known this for some time. But the meeting is another opportunity for dialogue. So maybe some of you can help with that agenda and make it an even better meeting. Thanks a lot.
Thank you. Okay, why don't we pause there, and then we'll start with the hand in the back on the next round of questions. Cornelius, would you like to address the question on child sexual abuse?
Yeah, I mean, I think that, we see the data that tells us that anywhere from 20 to 40% of young girls and about 10 to 15% of young boys that their first sexual experience is forced. And so we have to begin looking at how do we impact that? How do we begin to impact it in culture? And I think in a way that also isn't stigmatizing to any particular region, because this is a global phenomenon. And we've known for some time, for example, in the United States, when you look at the data around young black gay men, I mean, one of the most common denominators is early childhood sexual abuse. And so we've got to begin thinking about this within a global perspective. Certainly with PEPFAR, we're focused on it in terms of how are we impacting transmission for young girls. But it is an important issue, and I think that the ambassador is very clear that the way we also have to begin thinking about it is really by naming it and by talking about it, and to really create a dialogue that begins looking programmatically at both the culture of rape, but also how we begin tailoring and designing programs for young girls and for young boys that reflect that. And in many places where even our health professionals are not able to talk about sexuality, they're not able to talk about human body parts, and they're not able to talk about what is really happening to these populations.
If I just might add really quickly, that the issue though too is the family within the family. And we're talking a lot about GBV and rape,
Right.
but we haven't really started dialogue in most places in the world with regard to where it's primarily happening, which is in the family.
Well, we think that that's right, and one of the elements of DREAMS is to engage the family in the dialogue. So if you look at the design of DREAMS, it's not only the public health system, the school system, but it's also the family, faith networks, everything that surrounds that child's life.
Cornelius, I'm sorry, while you're still on the spot, would you like to address the question on the community engagement during the pivot development?
Yeah, so with PEPFAR, we have what's called the country and regional operating planning process. And so every country that we fund that's at the COP-ROP level develops a plan annually. And in 2014, Ambassador Gooseby sent a cable to all countries encouraging civil society engagement in the COP process. Last year, we took that a lot further in our guidance to countries, and we opened up, we not only encouraged the planning process, but we also created a review process where we invited civil society, UNAIDS, the Global Fund, all of our partners to come to the table as we were making the decisions around funding. Because we believe that transparency is essential, but we also believe that that partnership in planning is essential. That we all know what resources are being brought to the table, particularly with the Global Fund and PEPFAR, but and with obviously the countries, but that we also learn better. So when civil society is at the table and when communities are at the table and we're not having an impact, for example, in a district, well, those community leaders often know why. And they can tell you, well, you know, that service that you're funding over there is on the wrong side of the river. Nobody goes over there. And so being engaged in that type of dialogue then helps us to make smarter decisions. And so we think it's essential. We think that we had a very good experience in the recent COP and ROP process that just ended 2 weeks ago, and we're looking forward to engaging it further in the year ahead.
Regan, did you want to speak to that as well?
Sure. I was just going to add that, I'm sorry, thank you. I was just going to add that, you know, I couldn't agree with you more in terms of civil society participation in the dialogue and the reality of young people not being able to afford to get there. But I was impressed that 92%, the cell phone penetration in South Africa alone is 92%. And while not all the phones are smartphones, there are enough apps that people can use that are keeping people connected. And I spent a lot of time with the young people when I was there trying to figure out whether they were really taking in information on health and or talking about this. Because I've been on social media a long time as a woman living with HIV, I have thousands of requests, like in 1 year, just basic information or basic connectivity requests. It would be a terrific opportunity to bring a private sector partner, private sector partners in to the AIDS response and have them partner with Durban. Maybe this is already happening, but to really think about some of the best ways that we can create platforms for young people to contribute, because they will. It just needs to be put out to them and communicated to them. And I'm going to sort of look into what's been put in place. I know they have a great team around Durban, but maybe making some connectivity to the private sector partners. The appetite's there, and really they're so willing to talk so openly about their needs, not just as advocates, but also as people living with HIV. If there's a way to embed that and get their messages shared live in a room, sometimes I think the technology isn't being leveraged as it should in this response. So we'll take a look at what's possible.
Thank you. Namande, you wanted to add something?
Yes. Thank you, Sarah. I also agree with the sentiment around involving communities. I get the piece about civil society. I think at another level that's important because those are activists, but at the local level, communities need to lead their own response. There's a program that I came across which makes a lot of sense to me. It's called AIDS Competent Communities, and there's a global coalition that's working on how to empower communities to participate in an organized kind of fashion as they engage with the scientific community. I think that's important. As to representation at the 2016 AIDS conference, I think that if communities have leadership and have access to scholarships to represent them at that conference, because we can't take everyone to the conference from the community. It's just identifying representative leadership within their coalitions that can be the voice for them to engage in a meaningful way with scientists at the Durban AIDS conference. Thanks. So competent communities, I would suggest that we look at that.
Thank you. Richard, would you like to respond to the question on TB and the migratory patterns?
Yes, certainly. Thanks. Thanks, David. Yes, I would agree with you that stigma is just as much a problem, a barrier to overcome with TB as it is with HIV. During our trip, we visited a district hospital in rural KwaZulu-Natal where they'd initiated a sort of community-led, a decentralized treatment process for people with MDR-TB. And we spoke to some of the people who'd gone through that process, including a health worker herself who'd been infected during the course of her work. And yes, stigma, they were, nearly all of them talked about the challenge of stigma from their own families, you know, very sadly in many cases. People are terrified of TB and the airborne nature of the disease, and you go to a hospital, you see everyone with the face masks. There's something very intimidating, of course, about being confronted with that, and therefore I think it was interesting and encouraging to see this emphasis on community led or you know, trying to get much of the treatment, getting people diagnosed and on the right drugs, and then continuing their treatment at home as much as possible, rather than enduring these incredibly lengthy, difficult spells at hospital of this, you know, really tough treatment and the adherence challenges that come with that. So yes, stigma, a big issue to confront. Oh, and sorry, and you asked about the regional implications as well, and yes, they came across very strongly to us as well. Key populations you mentioned in terms of TB, the mining community being right up the top there. And yes, the migration patterns are very, very important in understanding Southern Africa and the disease burden there. Things have slowed down a little bit because of the economic crisis that the region is confronted with right now, and the drought as well. But certainly, yeah, understanding the regional dynamics both of HIV and TB is critical in cracking both of those diseases in this region.
All right, let's take one more round of questions, and then we'll evaluate our time. Let's start in the back there, and then we have one in the front and one here.
Thank you very much. Carl Henn from the HIV/AIDS Twinning Center Project of the American International Health Alliance. First of all, we want to say that we're very pleased that the CSIS delegation met with the clinical associates at Osindiswini Hospital. That's a cadre that we've been supporting with PEPFAR resources. And I want to thank all the speakers. I have a question for Dr. Namande. What do you see as the key challenges to launching and scaling up Test and Start and PrEP, and how will South Africa meet the demand for both in terms of medications and human resources? And might that involve expanding the clinical associates program? And then for Cornelius Baker, if you could add how PEPFAR will assist South Africa to meet this challenge. Thank you.
Thank you. All right, we had a question up here. You can get a microphone right here in the front. Okay, we'll start with this one, because there's a microphone here, and then we'll come there. Go ahead.
I'm Alex Bush. I'm a Master's of Public Health student at George Washington University. I guess my question is for anyone, primarily regarding the role of young South African men in all of this. Like, there's been a lot of discussion on the great need to increase access of services to young women and girls. But ultimately, men are, typically the ones doing the raping and the ones, continuing on with gender-based violence. But according to most recent data from IHME, they're also now dying from AIDS-related illnesses at a greater rate than women are in South Africa, and are about half as likely to access antiretrovirals, even though the prevalence of HIV amongst men and women is starting to the gap is narrowing. So I guess if this is because of a need to increase male health-seeking behavior, or if it's a result of gender norms promoting healthcare as an unmasculine endeavor, if those are still persisting, whatever it may be, what do you see as the next steps in involving men in the process more, and why aren't we talking about the epidemic amongst men more?
Okay, thank you. Right here in the front, and then we'll speak to those questions.
Thank you. Hi, my name is Ana Maria, and I used to work for a global research and service organization that served over 26 countries in Africa. So I'm really happy to be here, and I would like to thank each and every one of you, first of all, for sharing your knowledge and experiences with us. Dr. Cates, I was really excited to hear the statistic that you shared with us that came out of the high-level meeting that more people are being initiating treatment than there are newly acquired infections. But I think we all know that a lot of the issue is really having to deal with long-term retention and re-engagement in care and making sure that people remain on treatment. And so we know that high-level decision makers and those policy makers, they're all focused on data when it comes to making the connection between communities and how they go about making decisions. But my question is mainly around how we feed that data back to the community in a meaningful way and how we translate it back to them to where, we can go back and say, this is why it's important and why these, life-saving ARTs are actually going to keep you around longer for your family and your community. Thank you.
Thank you for those questions. Let me start with the first one and go to Namande to speak on the rollout of test and treat and PrEP in South Africa.
Thank you for that question. Carl, as my colleague panelists indicated before 2000, no one thought we could implement treatment, antiretroviral therapy in the African continent. But we did it with a lot of success, and we've had to bend the rules. And as you know, South Africa has got a big clinical associates program supported by your organization, in fact, which the plan and the policy is actually to expand and increase the numbers of clinical associates. We will be tapping into your expertise in terms of training of all of that level or cadership of health professionals to assist us with that. Once policy has been set and the funding allocations have been committed, as is the case in the recent announcement by the Minister of Finance, we have additional resources now to the baseline of the current financial year to the tune of R1 billion South African rands to assist with those kinds of programs to make sure that PrEP and test and treat works. We will be supporting work around the replenishment of the Global Fund that will assist us with those programs as well. So we have a high level of confidence that it will work, and with partners like yourselves and the commitment of the government and our other funding partners, test and treat and PrEP should be successful in South Africa, like we have shown success in other areas as well, including with the implementation of medical male circumcision. Thanks.
Thank you. Cornelius, could you speak to the U.S. government support?
Yes, obviously South Africa is a very valuable partner to the U.S. government in the HIV response, and we are committed to helping in every meaningful way that we can. I think that one of the ways, which also goes to another question that was raised, is really around sharing our data in addition to our technical expertise and helping to ensure that there is a good both geographic focus and a population focus, and that we are analyzing through that sharing of data not only with the Ministry of Health but also with the communities. Where do we see problems? One data set that we're really taking a strong look at right now is around men's engagement in care. I mean, I think some of our assumptions were that men weren't being retained in care or that they weren't seeking care because of the male thing. But what we're learning is that once linked in care, men are having the same outcomes generally as women. And so what we see right now as the primary gap is actually getting men tested. and then linked into care. Women are generally being tested related to pregnancy or other women-specific health care, and men don't have natural systems for ongoing testing. But once they are tested and positive, they're delivering the same outcome. So we've got to focus a lot more on the front-end testing.
Sorry about that. I think we've somewhat addressed all of the questions in various ways, but does anyone else want to add to those?
Yeah, just a question that you asked about how do you translate or communicate the high-level political decisions or commitments, scientific advances to the community. On the one hand, I think a hallmark of the HIV response is that divide has not been as striking as many other illnesses and health challenges. I mean, there's a real connection that doesn't exist in many other realms. So that's very important. Doesn't mean it doesn't take work. That is what one of the purposes of the conference, actually connected to the other question about access. Access has always been raised as a challenge at these conferences. They're international conferences. They take place, usually they always take place somewhere else from where a lot of people live and people travel, and so that's a critical issue. I know the conference itself is always trying to find ways to connect people, whether it's through technology, additional scholarships. But just to bring both those points together, that is part of the response, right? It must be that those political commitments don't mean anything if the community is not part of them, engaged in them, understanding them. And I will say, and UNAIDS made a real point of this, the community was part of the high-level meeting. It wasn't that the community wasn't part of developing those goals and those commitments and pushing to get those in there. I think the challenge now is making them happen. So.
There you go. You got it.
Okay. Thank you. And I just wanted to add, to that, you raised an incredibly good point about adherence. And as we look at the problem of scaling up treatment, we also have to think about who is on treatment. Is it the same people? Are we retaining all those people in care? Are people cycling through? Who has resistance? As someone who's taken pills for 20 years, I can tell you it gets increasingly more difficult. And we all need support in terms of adherence clubs or mechanisms that help us stay on the treatment. One of the ways that I have found helpful, and I've heard other people living with HIV find helpful, is having a viral load test, which is now, we're seeing more and more places in Africa being able to do viral load tests. It's a very different indicator of your health and your relative infectious, or your viral load equates to how infectious you are. And so as a person living with HIV who have people around her who care about my wellness, that's something that they all sort of watch, and it's a very good incentive to adherence and to also involving other people in the game, as opposed to CD4 or CD4-CD8 ratio testing. This is a real, I think it's a breakthrough. I don't think that we're getting it to enough people and educating enough people about the value of viral load testing in terms of how it helps reduce stigma too, because when I tell people I'm virtually non-infectious, it's a lot easier for them to hand me the baby or let me jump in the pool or give them a sweaty hug, So I think it's, not that I give people sweaty hugs, so I can avoid it, but you know what I mean.
And if I could add just to the data piece as well, I formerly served as the country coordinator for PEPFAR in Uganda, and sharing data as part of our country operational planning process was critically important, and it was a part of our overall strategy for engagement with civil society. And as you know, there's a great deal of data that is available, and so teams being able to take the time and walk clearly through what data is being used, how it's being analyzed is important. I think there is a major data gap there between the amount of data that's available, what does it mean, how it should be used, and I think it's an opportunity for a more synergistic relationship between the policy developers and implementers and the community groups on the ground to come to a common understanding of what it means and then how to translate it back to communities. So, quick check of time here. Oops, my phone locked on me. We've got 10 more minutes, so I think maybe we could take one or two more questions, and that'll take us to the end of our time frame. Anyone else? All right, well then I guess we can close a little bit early. Let me, there was one here, so sorry. Go ahead.
I'm Robin Kelly, and I'm here because I'm an interested citizen. I work in Washington, D.C., but I do also appreciate the opportunity to be reflective. And thank you very much for that moment that we had, and definitely for Dr. Katz and Dr. Baker, who may have relatives or felt definitely moved by what happened, the massacre in Orlando. My condolences if you had relatives there or do have relatives there that might have been infected. My question really goes to Dr. Katz in terms of the Global Fund and the replenishment of that. I know that the goal is 2030 to really sort of stop AIDS, but what is that in terms of replenishment and in terms of looking at it in HIV and helping others get the word out and implementation?
Really good, great question, because I was actually looking down right as you were speaking at the thing I wanted to end with, which is about funding and resources. The really ambitious goals that were agreed to by all member states for ending the AIDS epidemic by 2030 are predicated on doing a set of things by specific time slots. So that's good, right? We have very specific targets, know what the plan should be, know how the science is there, know how to get there. Resources are a key part of it. They're not the only part of it. And if you look at the actual resource projections for what's needed, UNAIDS has identified how much was available in 2014 and how much is needed by 2020, so in 4 years from now. It's a pretty significant leap. And in fact, right in the 2014 estimate of what was available, about half was provided by the international community, the Global Fund, PEPFAR, other donors, foundations, and about half by governments themselves, people out of pocket, et cetera. A little bit more international. By 2020, far more than half is estimated or projected to be needed by domestic sources alone. So the challenge is going to be a big one. This assumes that the donor funding isn't going to be as great. We've seen it start to level off. The Global Fund is obviously a critical part of it and is going to be having replenishment this fall in September, where donors and others will hopefully will pledge to the Global Fund for another 3-year period. There's already been commitments received for that, but it's a critical part of this. And so I encourage anyone who is following this or wanting to get engaged at that moment. So we talked about the moments that are important. There's Durban. The Global Fund replenishment will be a really key moment in the fall. It's going to be hosted by the Canadian government. And that will be a marker, because that will come after the high-level meeting and will show what is the world, what are our donors willing to commit to. And if that falls short, I think there's a cause for concern. If the pledging conference is a success, I think that is, we can have a little bit more optimism. But beyond that, let's say the pledging conference is a big success, and I hope it is, there is still going to be an uphill battle, because assuming that most of the resources are going to be available from those countries that are affected by the epidemic is a big lift and a big challenge. As we heard, the economic crisis, the drought, et cetera, these are trying times, and I don't think it's going to be easy. So thanks for your question.
Okay. I'd like to just give the opportunity to any of our panelists to offer any closing comments or remarks. Okay.
I'd like to conclude and close by saying that the South African government thanks CSIS for its strategic decision to take South Africa as an important country, especially in the health sector relations with the UN. And we have managed to move the needle around what needs to be done between the two countries in the area of health, assisted by some of the work that you do. The Durban 2016 will be co-chaired by South Africa and the US. In the health sector, we really joined at the hip between the two countries, and we're working together to solve the problems in that space. I would like to make the point that South Africa is a stable and resilient democracy. It is committed to the fight against HIV and AIDS, as demonstrated by the work we've managed to do up to this point, even in the context of where there might be political turbulence, which you find anywhere else. we're not about to drop the ball in this area of the fight against HIV and AIDS, and partnerships with you, all of yourselves in the room, are much appreciated. Thank you for inviting us once again. Thank you.
Thank you again to all of you for your participation today and your very thoughtful remarks. And thank you all for joining us. I'll just close by extending an invitation to our next event, which will be next Thursday. We will be showing our documentary on the epidemic of fear during the Ebola outbreak, which will be followed by a panel discussion by journalists from print, radio, and TV. That'll be next Thursday afternoon at CSIS, and we hope to see you there. Thank you.